Welcome to the Radon Smart Review GU Cancer Series.
Imagine looking a 54-year-old man right in the eye, telling him he has cancer, and then
telling him the absolute best medical decision you can make for him today is to do literally nothing.
right, doing absolutely nothing. So today, we're really mastering the art of active surveillance, watchful waiting, and low-risk prostate cancer management.
Yeah, so think back to the foundation we built in our first two tutoring sessions. We established that really complex anatomic framework of the pelvis.
Exactly. And we went through the risk stratification system step by step, right? We mapped out the standard diagnostic workup pathway.
We did. We covered exactly how to find the cancer and, how to stage it. But today, the mission is entirely different.
Oh, completely different. Today, you have to answer the most crucial and undeniably the most psychologically taxing question that a newly diagnosed patient is going to ask you in the consultation room.
And that question is, do I actually need treatment?
Right. And that is exactly where prostate cancer wildly diverges from almost every other solid tumor you're going to encounter during your residency training.
For sure. I mean, if you're on a thoracic rotation and you find an early stage lung cancer, or you're on a breast service and find a localized carcinoma.
Or colon cancer, right.
Right.
The medical consensus is almost universally immediate action.
Yeah, you cut it out, you radiate it, or you deliver systemic therapy as soon as safely possible.
But for very low and low-risk prostate cancer, the answer is uniquely and honestly, often incredibly frustratingly for the patient, not yet.
We need to be crystal clear from the jump here. Active surveillance is not a compromise.
No, not at all. It's not a deferral born of limited hospital resources or, a lack of surgical capacity.
Exactly. For very low and low-risk disease, it is the absolute definitive guideline-preferred management strategy.
And we have to be incredibly precise with our language when we talk about this, because semantic sloppiness leads straight to clinical errors.
Right. I mean, surveillance is not the same as just ignoring the patient.
No. And it is certainly not a blanket approach appropriate for everyone who walks through your door.
So this lecture is entirely about drawing definitive clinical lines in the sand.
Yeah, we need to define exactly who qualifies for surveillance and exactly how you monitor them using rigidly structured intervals.
Plus, what specific clinical or pathologic changes mandate pulling the ripcord, right? Triggering definitive treatment.
Crucially, yes. And when the patient actually needs definitive therapy right now, despite having ostensibly low-risk disease on paper.
So we're going to break this down into three core pillars. First, we'll meticulously dissect the distinction between active surveillance and watchful waiting.
Which represent two fundamentally different philosophies of care, right?
Wow.
And they are frequently and dangerously confused by junior residents on the wards.
Second, we'll tear into the highest yield evidence comparing surveillance to immediate treatment. We'll specifically look under the hood of the 15-year outcomes from the PROTECT trial.
And the Swedish registry data, too.
Yep. Third, we're going to explore the clinical judgment required to know when a low-risk patient should just bypass surveillance entirely and be treated immediately.
All right, well, let's anchor all of this theory in a real-world clinical scenario. Picture this patient sitting right across from you.
Okay, you're seeing a 54-year-old man. He is entirely healthy.
So, good baseline.
Yeah. He runs 3 miles a day, takes no daily medications, and has literally zero medical comorbidities.
Wow, okay.
He was referred to your radiation oncology clinic after a routine primary care screening showed a PSA of 4.8 nanograms per milliliter.
And what about the physical?
His DRE, or digital rectal exam, is completely normal. You feel a smooth, symmetric gland with no nodules.
So clinical stage T1C.
Exactly. Then he underwent an MP-MRI of the prostate, which showed a small PIRADS3 lesion in the left peripheral zone.
Okay, PIRADS3. Indeterminate.
Right. Based on that, he had a combined MRI, targeted and systematic transrectal biopsy. The pathology report lands on your desk.
What did it show?
It reveals Gleason 3 plus 3 equals 6, which translates to grade group 1, found in 2 out of 14 cores.
And the volume.
The maximum core involvement in those positive samples is 20%. His calculated PSA density is 0.11.
And perineural invasion.
No perineural invasion identified by the pathologist.
Okay. So this 54-year-old gentleman leans forward in his chair. He's clearly anxious, tapping his foot, and he shares his dilemma with you.
What does he say?
He says, "Doc, I was at the golf course this weekend, and I confided in my buddies about my diagnosis. One friend had what sounded like the exact same diagnosis, and his doctor told him to just watch it.
Right.
But another friend had the exact same thing, and he was rushed to surgery the very next week, and now he's telling me he has to wear adult pads every day.
That is such a common clinic conversation.
It really is.
Mm.
He asks, which path is right for me? How do I know what to do when even the doctors seem to disagree?
If you're going to specialize in GE radiation oncology, this is the exact conversation you're going to have more than any other.
Yep. Your ability to answer his question clearly, citing the actual data without overwhelming him and genuinely reassuring him is the hallmark of a competent attending.
Now, let's step out of the clinic for a second. Imagine you are sitting in a hotel room in Chicago for your oral boards. The examiner hands you this exact case scenario on a piece of paper.
High-pressure situation.
Exactly. This is your moment. I'm going to act as the examinee right now, and I'll deliver the 60-second board script exactly as you should recite it to pass the station with flying colors.
All right, listen to the structure, the criteria, and the intent here, folks. The floor is yours, doctor.
This is a 54-year-old healthy man with PSA-detected prostate cancer. PSA 4.8, T1C by DRE, grade group 1, Gleason 3 plus 3, in 2 of 14 cores with 20% maximum involvement. PSA density is 0.11. He meets all criteria for NCCN, very low-risk disease, T1C, GG1, PSA below 10, fewer than 3 positive cores, less than 50% involvement of any core, and PSA density below 0.15. Active surveillance is the preferred management for very low-risk disease in patients with life expectancy of 10 years or more. This is not watchful waiting. AS uses structured monitoring with PSA, DRE, MRI, and serial biopsies with the intent to deliver curative therapy if the cancer reclassifies. Watchful waiting, by contrast, forgoes surveillance biopsies and treats only for symptoms. The distinction matters because the intent, curative versus palliative, drives the entire monitoring framework.
That is the exact, concise, authoritative delivery the examiners want.
Nailed it.
You immediately categorized his risk, you rattled off the specific NCCN criteria without hesitation, and you recommended the guideline-preferred treatment based specifically on his life expectancy.
Yeah, and crucially, I preemptively demonstrated that I know the critical difference between surveillance and watchful waiting.
By unpacking that last point, we get into arguably the most common and frankly the most egregious error in prostate cancer counseling.
Why does the semantic difference between active surveillance and watchful waiting completely change your entire clinical workflow? I mean, it's not just a matter of terminology, is it?
Not at all. It changes everything because it fundamentally alters the underlying intent of your medical care.
That's about intent.
It's the absolute dividing line between a curative intent strategy and a palliative intent strategy.
Okay, let's break that down. When you place a patient on active surveillance, or AS,
You're monitoring the cancer with the explicit, definitive expectation of delivering curative therapy down the road.
right, it means you are fully prepared, and the patient is fully prepared, to proceed with a radical prostatectomy, or definitive EBRT, or brachytherapy.
Exactly. The very moment the disease progresses or reclassifies to a higher risk state, you act.
So you aren't ignoring the cancer, you're actually actively stalking it.
That's a great way to put it. You're implementing a highly structured schedule of PSA blood tests, DRD physical exams, high-resolution MPMRI scans.
And crucially, serial prostate biopsies.
Yes. The entire goal here is to defer the significant life-altering morbidity of treatment.
We're talking about delaying the potential for permanent urinary incontinence, erectile dysfunction, and, debilitating bowel toxicity for as long as the cancer remains indolent.
But the vital part of this equation is that you're doing this while perfectly preserving the window for a definitive cure.
Right. Because of the intensive monitoring and the curative intent, AS is explicitly reserved for patients with a calculated life expectancy of 10 years or more,
Contrast that aggressive monitoring with observation.
which in the literature and in practice is often used interchangeably with watchful waiting, or WW.
Right. Observation is strictly a palliative intent strategy.
So when you put a patient on observation, you have conceptually abandoned the idea of curing the prostate cancer.
Exactly. You're monitoring the clinical course of the disease with a basic history and physical exam, usually no more often than every 6 to 12 months.
Crucially, and this is the biggest distinction for your oral boards, there are absolutely no surveillance biopsies in a watchful waiting protocol.
None. You are only going to intervene and offer treatment if the patient develops actual physical symptoms from the cancer.
Like a urinary obstruction or, God forbid, severe bone pain from a metastatic lesion.
Right, and then that treatment would typically be systemic therapy or palliative radiation, not curative.
The goal of watchful waiting is purely maintaining quality of life for older or frailer patients.
We're talking about the 80-year-old with a previous myocardial infarction and severe emphysema.
Where those existing medical comorbidities are highly likely to outcompete the prostate cancer as the ultimate cause of death.
You're looking at the whole patient and recognizing that subjecting them to the trauma of treating the prostate cancer will only cause them harm.
Yeah, it'll degrade their remaining quality of life without adding a single day to their overall survival.
To ground this conceptually, look at the older natural history data from the pre-MRI era that the NCCN often references.
What did that show?
Researchers found that only about 13% of patients developed metastases 15 years after a diagnosis of T0 to T2 disease in an observation setting.
Just 13%, wow.
Right. While we don't use that historical data as a precise modern benchmark for treatment, it beautifully illustrates just how glacially slow this disease can move.
So observation means you've made a calculated medical decision that the cancer simply won't be the thing that ends their life.
If you only take one thing from this session into your oral boards, and more importantly, into your clinic tomorrow, it's this distinction.
You must burn this specific mnemonic into your memory. Ready? AS equals structured monitoring with curative intent. Observation, or WW, equals symptom triggered palliation with quality of life intent. The switch happens when LE drops below 10 years.
It's that important. Say it again.
AS equals structured monitoring with curative intent. Observation, or WW, equals symptom triggered palliation with quality of life intent. The switch happens when LE drops below 10 years.
Perfect. So with that foundation laid, let's build the clinical decision-making framework.
We're going to construct the if-then risk ladder. This is the exact algorithm you need to automatically apply to every single new consultation you see.
Step 1 on the ladder, very low-risk disease.
If a patient has very low-risk disease, then AS is strongly preferred, assuming their life expectancy is 10 years or more.
You have to know the NCCN criteria for very low risk flawlessly. It's a strict checklist, and it requires all of the following to be true.
Let's list them. First, clinical stage T1C.
That means the tumor was completely non-palpable on your DRE. You only found it because an elevated PSA led to a biopsy.
Second, grade group 1, meaning Gleason 3 plus 3 disease.
Third, a PSA strictly below 10 nanograms per milliliter. Why 10? Because historically and biologically, once the PSA crosses 10, the statistical risk of microscopic systemic escape and biochemical failure rises significantly.
Fourth, fewer than 3 positive biopsy cores.
Fifth, less than 50% involvement of any single core. Those core metrics confirm the spatial volume of the tumor is tiny.
And finally, a PSA density below 0.15 nanograms per milliliter per gram.
Let's pause on PSA density for a second, because residents often memorize the 0.15 cutoff without understanding why it matters.
Yeah, let's explain it. PSA density is just the absolute PSA value divided by the total volume of the prostate gland in cubic centimeters or grams, usually measured on the MRI.
But why do we care? Because benign prostatic hyperplasia, or BPH, also secretes PSA.
Right. If a man has a giant 80-gram prostate and a PSA of 6, his density is extremely low.
That PSA is likely just coming from a massive, benign, inflamed gland.
But if a man has a tiny 20-gram prostate and a PSA of 6, his density is 0.30.
That's a huge red flag. A small gland shouldn't be producing that much PSA unless there is a dense, hyperactive malignancy inside it.
That makes total sense. That's why the strict cutoff of 0.15 exists for very low risk.
Exactly. If they meet all those criteria, and they have the 10-year life expectancy, you are pushing strongly for active surveillance.
Moving to step 2 on the ladder, low-risk disease.
If the patient is low risk, meaning they have clinical stage T1 to T2A, they still have grade group 1 disease, and their PSA is still below 10 meg.
But perhaps they have 3 or 4 positive cores, so they miss the strict, very low-risk volume criteria.
Right. AS is still the strongly preferred approach for the vast majority of these patients.
Both the AUA and the ASTRO localized guidelines are in lockstep here, recommending AS as the preferred approach.
But hold on, though. You're making this sound black and white, But what about a guy with favorable intermediate risk disease?
Yeah, that's a great question. For decades, the dogma in urology and radiation oncology was that the second we saw Gleason pattern 4 on a slide, we rushed them to the OR, or the LINAC.
Are you saying we're legally and ethically allowed to just watch a Gleason 7?
It's the most hotly debated topic at every major GU oncology conference right now. The short answer is yes. Active surveillance can be offered for selected, favorable, intermediate risk patients.
But the word selected is doing a monumental amount of heavy lifting there.
Oh, absolutely. We aren't just opening the floodgates to everyone with pattern 4 disease.
So how are we selecting them? Who actually gets a pass on immediate treatment if their biopsy shows a Gleason 3 plus 4 equals 7?
We are looking for the absolute best actors within that intermediate risk category.
Okay, meaning what, specifically?
These are candidates who have a microscopically low volume of Gleason pattern 4. When the pathologist looks at the slide, the pattern 4 might only represent 5% of the overall tumor volume.
So their overall tumor volume across all the biopsy cores is exceptionally low.
Yes. Their PSA density is low, ideally well below that 0.15 threshold we just discussed.
And increasingly, we're relying on favorable genomic classifier scores like Decipher or Polaris if that testing was obtained.
Right. If the genomics come back showing a low-risk molecular signature despite the pattern 4 histology, the AUA and ASTRO guidelines explicitly support discussing surveillance alongside definitive treatment for these highly selected men.
But we have to exercise extreme caution here. There are specific clinical variables that should immediately tilt your judgment away from surveillance and back toward definitive treatment, even if they technically meet the broad criteria for favorable intermediate risk.
Like what?
If they have a higher volume of pattern 4, say 20 or 30% of the core, you treat.
If their PSA density creeps above 0.15, you treat.
If they have a PRADS 4 or 5 lesion on their MPMRI, which strongly suggests dense cellularity and predicts a much higher risk of biopsy progression during surveillance.
You lean heavily toward treatment.
Another critical factor to consider is African American race. We'll explore the underlying mechanisms of this later, but African American men have historically been shown to have higher rates of pathologic upgrading.
So if an African American patient has intermediate risk disease, the threshold to intervene should be lower.
Right. And finally, if they have elevated unfavorable genomic classifier scores, that's a glaring molecular red flag.
It tells you the biology of the tumor is far more aggressive than the microscope suggests, and definitive treatment is warranted.
Let's shift gears into the actual mechanics of the active surveillance protocol and what I call the PSA kinetics trap.
Okay, so you have a patient, you've gone through the shared decision-making process, and you've mutually agreed on active surveillance. What happens the moment they leave the clinic?
Do you just shake their hand and say, "See you in a year"?
Absolutely not. The first and arguably the most critical step of any AS protocol is confirmatory testing.
You have to conceptualize what a prostate biopsy actually is. Even a modern MRI-targeted transperineal or transrectal biopsy is essentially a blind sampling procedure of a walnut-sized gland.
Yeah, it is entirely possible and frankly common that the initial biopsy needles simply missed a tiny, aggressive pocket of higher-grade disease.
Therefore, rigorous confirmatory testing is strongly recommended within 6 to 12 months of the initial diagnosis to prove they actually belong on surveillance.
This confirmatory workup must absolutely include an MPMRI to get that precise PSA density calculation, assuming they didn't already have a high-quality scan prior to the first biopsy.
And crucially, it requires a confirmatory prostate biopsy.
Now, a quick note on those molecular tumor analyses we mentioned, Decipher, Oncotype DX, Polaris.
You can consider ordering these if the results would genuinely practically change your decision between AS and definitive treatment.
But you must understand their limitations. One major study demonstrated that these molecular tests did not significantly improve risk stratification over standard clinical variables alone when it came to accurately predicting who would upgrade on a subsequent surveillance biopsy.
Yeah, they're tools, not crystal balls.
And let's highlight a massive warning sign regarding the MRA.
If a patient has a highly suspicious PIRADS 4 or PIRADS 5 lesion on their initial MPMRI, but the biopsy pathology only returns grade group 1 disease, you have a severe risk of undersampling.
A PIRADS5 lesion represents restricted diffusion and dense cellularity. It's practically screaming that clinically significant cancer is present.
Right. If the needle only found indolent Gleason 6, the needle likely missed the true target.
That patient is at a significantly increased risk of biopsy progression during AS and warrants particularly rigorous monitoring.
Regardless of the MRI findings, all patients on AS should undergo a confirmatory biopsy within 1 to 2 years of their diagnostic biopsy.
So once you get past that initial confirmatory phase and prove the cancer is truly low risk, you enter ongoing monitoring. What does that schedule actually look like?
The guidelines from AUA, ASTRO, and NCCN provide a framework, but they are intentionally designed to be somewhat flexible to allow for individualized, patient-centered care.
Generally speaking, you are drawing a PSA every 6 to 12 months.
You are performing a DRE annually to check for palpable changes.
And you are ordering periodic MPMRI scans and repeat prostate biopsies every 1 to 4 years.
The NCCN specifically provides upper bounds to protect the patient's quality of life.
Yeah, they suggest checking the PSA no more often than every 6 months and doing the MRI and biopsy no more often than every 12 months.
Why? Because over-monitoring burns the patient out. Every biopsy carries a risk of sepsis, bleeding, and immense anxiety.
The core principle is a confirmatory biopsy early on, followed by tailored intervals based on their life expectancy, their personal biological risk of reclassification, and their psychological tolerance for the surveillance process.
Oh, and repeat molecular tumor analysis during the course of AS is explicitly discouraged.
Right, once you have the baseline genomic signature, you don't need to keep running those expensive tests. The biology generally doesn't shift that rapidly without histologic changes.
Okay, picture this. It's 4 p.m. on a Friday. Your intern comes sprinting into the attending workroom, completely panicked.
Oh boy.
He says, "Doctor, we have a crisis with Mr. Johnson. He's on active surveillance for very low-risk disease. His PSA 6 months ago was 3.0. Today, the lab just resulted at 5.0. If you do the math, his PSA doubling time is well under 3 years. We need to abandon surveillance immediately. I'm going to call urology to book a salvage prostatectomy, or we need to simulate him for definitive EBRT first thing Monday morning."
Yikes. What do you tell that intern?
As the attending, I would tell that intern to sit down, take a deep breath, and actually look at the historical data, because they have just fallen headfirst into the PSA kinetics trap.
You cannot, under any circumstances, let a PSA fluctuation replace a tissue biopsy.
Yes. Historically, older protocols, most notably the famous Toronto cohort in its early days, actually used a PSA doubling time below 3 years as a hard, definitive trigger for reclassification and treatment.
But we have learned an immense amount about the biology of the prostate since then.
Precisely. Both the Toronto group, when they looked back at their own data retrospectively, and the massive Johns Hopkins AS cohort, definitively concluded that PSA kinetics are simply not reliable enough to serve as an independent trigger for definitive treatment.
In the rigorous Hopkins data, neither the absolute PSA level nor the PSA velocity was strongly associated with actual pathologic biopsy reclassification.
The NCCN guidelines explicitly state that PSA doubling time is not considered reliable enough to be used alone to detect disease progression.
You have to remember basic anatomy. The prostate is a gland, it gets inflamed.
Right. Benign prostatic hyperplasia grows over time. Prostatitis flares up asymptomatically.
A patient might have ridden a bicycle for 20 miles before his blood draw. PSA bounces around for dozens of physiologic reasons that have absolutely nothing to do with cancer progression.
So what is the correct clinical action?
A rapidly rising PSA is a smoke alarm. When a smoke alarm goes off, you don't instantly bulldoze the house. You go look for a fire.
A rising PSA should prompt you to strongly consider repeating the MPMRI and performing another targeted biopsy.
But it never, ever triggers definitive treatment by itself. You treat based on pathologic or radiographic proof, not a math equation based on a fluctuating blood protein.
So if PSA doubling time is just a smoke alarm, what actually forces our hand? What is the undeniable proof that this cancer has woken up and requires intervention?
Let's break down the validated triggers for reclassification.
The absolute gold standard, the primary indisputable driver for transitioning a patient from surveillance to definitive treatment, is grade reclassification on a repeat biopsy.
Specifically, if you see a grade group upgrade to grade group 3 or higher, meaning the pathologist sees Gleason 4 plus 3 equals 7 or above, that is a glaring, unavoidable signal to recommend immediate curative treatment.
The biology has fundamentally shifted.
And if they upgrade to grade group 2, Gleason 3 plus 4,
As we debated earlier, that remains a gray area requiring intense clinical judgment.
If it's a tiny microscopic volume of pattern 4 and their genomics are favorable, you might discuss continuing surveillance.
But if it's a larger volume of pattern 4, the balance tips heavily toward treatment.
Aside from grading, other clear triggers include increased tumor volume on the biopsy.
Even if the histology stays stubbornly at grade group 1, if the tumor is suddenly found in 8 out of 12 cores instead of the original 2,
Or if the percentage of cancer involvement in a single core jumps from 10% to 80%, the overall burden of disease has massively expanded.
the tumor is growing and treatment is warranted.
We also rely heavily on radiographic and clinical progression. MPMRI progression is a major trigger.
If you're reviewing the annual scan and you see a brand new suspicious lesion, or if a previously stable indolent PIRADS3 lesion suddenly enlarges and becomes a PIRADS 4 or 5.
That is a hard trigger for a targeted biopsy and very likely subsequent treatment.
Similarly, a physical change in the DRE, like suddenly feeling a brand new, hard, palpable nodule that wasn't there last year, which is then confirmed histologically, means the disease is progressing locally and requires action.
And we cannot ignore the psychological aspect of this disease.
Patient anxiety is a completely valid, legitimate, and frankly incredibly common factor for ending surveillance.
In the Toronto experience, about 3% of the men who eventually left active surveillance did so entirely because of debilitating, intractable anxiety, not because their cancer actually progressed biologically.
We're treating human beings, not just lab values. Living with untreated cancer is a profound mental burden.
If a patient sits in your clinic and says, "Doc, I can't sleep, this is destroying my marriage, I can't focus at work," then definitively treating the cancer to relieve that psychological torment is the correct medical decision.
We are effectively treating the patient's anxiety, not their cancer, and that's a completely valid medical intervention.
Let's do a deep dive into the actual data from the major surveillance cohorts. Because when a patient is spiraling with anxiety, this is the data you need to quote to reassure them, and frankly, to reassure yourself.
Let's start with the Johns Hopkins cohort. This is the holy grail of AS data.
They prospectively followed men with very low and low-risk disease, utilizing incredibly strict annual surveillance biopsies.
What did they actually find when they looked at the data at the 15-year mark?
The Hopkins data is staggering, and you absolutely must know these numbers for your boards. At 15 years, 31% of the men experienced grade reclassification.
Think about that biology. Nearly 1/3 of the men eventually had their cancer grow or upgrade to a more aggressive phenotype.
As a direct result of that reclassification and other triggers, 57% of the men received some form of curative intervention surgery or radiation by year 15.
The median time they spent entirely treatment-free was 8.5 years.
A junior resident might hear those numbers and say, wait a minute, more than half of them failed surveillance and needed treatment anyway. If there's a flip of a coin chance they'll need surgery eventually, why not just treat them all on day one and be done with it?
You don't treat them on day one because of the survival statistics.
Despite the fact that 31% reclassified and 57% eventually got treated, their prostate cancer-specific survival, their CSS, at 15 years was an astonishing 99.9%.
Their metastasis-free survival was 99.4%.
Let me say that slower because it is the most important statistic in this entire tutoring session. 99.9% cancer-specific survival at 15 years.
That means out of 1,000 men, only 1 died of prostate cancer.
What this fundamentally proves to the medical community is that reclassification is not a failure of the surveillance protocol.
Reclassification is proof that the protocol works perfectly.
The highly structured monitoring system caught the progression, it caught the cancer declaring itself biologically in plenty of time for curative treatment to be delivered successfully.
We spared half the men the morbidity of treatment entirely for the rest of their lives, and the half that eventually needed treatment were still cured.
That is the ultimate triumph of active surveillance.
We see these exact same themes echoed in the other major global cohorts. Look at the Toronto cohort.
They included mostly low-risk patients, but they bravely included about 20% intermediate-risk patients as well.
At a median 7-year follow-up, 23% met their reclassification criteria.
Interestingly, when you look closely at why they left, only 8% actually had a true Gleason grade increase.
14% hit that old, now outdated PSA doubling time trigger of less than 3 years, and 3% were treated purely for anxiety.
Their actuarial 15-year cancer-specific survival was an excellent 94.3%.
And crucially, when you look at all-cause mortality, these men were 9 times more likely to die of a heart attack or a stroke or another non-prostate cause than they were to die of their prostate cancer.
The Dutch PRES study reinforces this landscape even further. By 10 years, between 50 and 70% of men discontinued AS, mostly driven by Gleason upgrades or increased core positivity on repeat biopsies.
But at the 10-year mark, 94% of the entire cohort were totally disease-free, including the men who got treated after leaving AS.
The ultimate teaching synthesis you need to deliver to your patient is this. You must set realistic expectations on day one.
You look them in the eye and tell them, there is roughly a 50% chance you will need treatment at some point in the next 10 to 15 years. It's a coin flip.
But by watching it in this highly structured, rigorous way, we guarantee you maintain your normal quality of life right now.
And the data proves that waiting does not compromise our ability to completely cure you later if the cancer changes.
Now let's shift to the massive randomized trials. It's one thing to look at observational cohorts, but we need randomized evidence comparing AS directly with immediate treatment.
The absolute giant in the room here is the PROTECT trial out of the UK. We discussed the natural history findings of PROTECT in Part 1, but now we need to dissect it through the lens of modern management comparisons.
The PROTECT trial was a monumental, historic undertaking in urologic oncology. They randomized 1,643 men with PSA-detected localized prostate cancer.
The population was heavily skewed toward the lowest risk categories. 77% of the men had grade group 1 disease, and 76% were clinical stage T1C.
They randomized these men into 3 distinct arms: active monitoring, radical prostatectomy, or definitive EBRT.
The radiation arm specifically consisted of 74 gray delivered in 37 fractions, combined with 3 to 6 months of ADT, or androgen deprivation therapy.
So what actually happened to these men at the 15-year follow-up mark?
The most critical headline-generating finding was that prostate cancer-specific mortality was statistically identical across all 3 arms.
It was incredibly low across the board, hovering around 1.5 to 2.2%, regardless of whether they were monitored, cut, or radiated.
All-cause mortality was also identical at around 15 to 16%.
But, and this is a massive but that you must understand to safely practice medicine, the active monitoring arm had clearly, demonstrably higher rates of metastatic disease.
Approximately 9% of the monitored men developed painful, incurable bone metastases by 15 years, compared to only 4 to 5% in the surgery or radiation arms.
Clinical progression was also much higher, about 21% in the monitoring arm versus 8% in the treatment arms.
And by 15 years, 61% of the men originally assigned to active monitoring had crossed over and received definitive treatment anyway.
This is where you, as a critical appraiser of medical literature, have to step in and add the necessary nuance to the PROTECT trial, because it is dangerously easy to misinterpret those metastasis numbers and panic your patients.
The PROTECT trial used a protocol they deliberately called active monitoring.
This is fundamentally, structurally different from the modern active surveillance we practice today.
The PROTECT protocol did not mandate systematic serial MPMRI scans. It did not mandate systematic serial confirmatory biopsies.
They were largely just passively watching the PSA blood tests and waiting for clinical symptoms.
Exactly. It was a passive, almost primitive monitoring system compared to the high-tech surveillance we do now.
Modern AS protocols, which are deeply integrated with high-resolution MRI and precision-targeted biopsies, are designed to detect that microscopic clinical progression much, much earlier than a blood test alone.
The prevailing hypothesis in the oncology community is that modern AS should significantly narrow or perhaps completely eliminate the gap in metastatic rates that we saw in PROTECT.
Furthermore, as radiation oncologists, we have to look critically at the radiation arm of PROTECT.
They used older 3D conformal radiation techniques, delivering only 74 gray. In the modern era, that is considered a suboptimal dose.
Today, we use dose-escalated, highly conformal IMRT or VMAT, routinely delivering 78 to 80 gray.
The toxicity profiles and potentially the long-term local control rates from PROTECT simply do not perfectly reflect the capabilities of modern radiation oncology.
But even with those older techniques, the functional outcomes from PROTECT are incredibly valuable for patient counseling. They give us a stark, honest look at the physiologic trade-offs of our treatments.
The radical prostatectomy arm, unsurprisingly, had the worst urinary incontinence. 46% of the surgical patients required pad use at 6 months due to sphincter damage.
And even at 6 years out, 17% of those men still needed pads every single day.
On the other side of the coin, the radiation arm had the worst bowel symptoms, driven by radiation proctitis. About 6% of the men reported bothersome blood in their stool at 6 years.
When it came to erectile dysfunction, both surgery and radiation caused significant life-altering issues, but the functional trajectories were completely different.
Surgery caused immediate, profound ED right out of the gate, due to the severing or stretching of the neurovascular bundles, which then partially recovered over a year or two for some men.
Radiation, which damages the microvasculature over time, caused a much slower, gradual decline in erectile function over several years.
And here is the truly fascinating, often overlooked part about the monitoring arm. Initially, those men beautifully preserved all their functional domains.
They had no immediate incontinence, no immediate bowel issues, no immediate ED.
But because 61% of them eventually needed to cross over to treatment, and because natural aging severely degrades erectile function anyway.
By year 12 of the trial, the rates of erectile dysfunction actually converged across all 3 arms.
Whether they had surgery, radiation, or monitoring, they all ended up in a very similar place, functionally, at a decade out.
To add one more layer of observational data to this puzzle, we look to the Swedish National Prostate Cancer Register, specifically the Statin 2010 data.
They looked at a massive, population-based cohort comparing surveillance, surgery, and radiation in the real world.
For low-risk disease, the 10-year prostate cancer-specific mortality was 2.4% with surveillance versus 0.7% with definitive treatment.
Let's contextualize that math. The absolute difference in mortality between watching and treating low-risk disease at 10 years is less than 2%.
That remarkably small absolute difference strongly supports AS as a profoundly safe, viable strategy.
However, the difference is not mathematically zero, and that tiny non-zero risk of mortality is precisely why we must utilize rigorous, structured, MRI-based monitoring rather than just passively observing these men.
We are actively trying to drive that 2.4% down to the 0.1% perfection we saw in the Hopkins cohort.
Let's pivot to a very practical, technical point for radiation planning. This is the treatment techniques: field, volume, and basin call-out.
This requires a conceptual shift, a complete re-anchoring of your risk assessment.
Imagine a patient who enters your active surveillance program with grade group 1, highly favorable disease.
3 years later, their scheduled surveillance biopsy comes back and it shows they have unfortunately reclassified.
They now have grade group 2, Gleason 3 plus 4 disease, perhaps with a much higher percentage of core involvement.
They are ready for treatment, and you are now going to simulate and plan them for definitive EBRT.
The absolute critical rule here is that you do not anchor your treatment plan to their original historical diagnosis.
You plan your clinical target volume, your radiation technique, your nodal coverage, and your total dose based entirely on their new current risk classification at the exact time of treatment.
Think of it like fighting a forest fire. When the fire starts, it might just be a tiny spark from a campfire.
If the fire department arrives 3 hours later and 3 acres of dense forest are burning, they don't deploy their water trucks based on the size of the original spark.
They fight the fire based on the massive size of the blaze today.
In prostate cancer, if a patient reclassifies from low risk to favorable intermediate risk, you treat them exactly as you would a de novo favorable intermediate risk patient who just walked in off the street.
You restage them. You recalculate their new risks of microscopic seminal vesicle or pelvic nodal involvement, and you expand your target radiation volumes accordingly.
Now we need to cover the controversies and the advances in the field, specifically looking at the exceptions to the rule.
We have thoroughly established that AS is the gold standard for low-risk disease. But, as we constantly say in medicine, most is not all.
When do we look at a technically low-risk patient and definitively decide they need to be treated immediately?
There are several distinct, highly debated clinical scenarios that should push the conversation away from surveillance and toward the operating room or the LINAC.
The first major exception is young age combined with a very long life expectancy. Consider a 50-year-old man diagnosed with grade group 1 disease.
He is healthy. He likely has 35 or 40 years of life ahead of him.
If we extrapolate the Hopkins data, which showed a 31% reclassification rate at just 15 years out to 30 or 40 years, it becomes statistically highly probable, if not almost an absolute certainty, that a 50-year-old will eventually experience biologic grade reclassification and require treatment at some point in his long life.
Exactly. For these very young patients, they're staring down the barrel of decades of serial biopsies, decades of PSA anxiety every 6 months, and the looming inevitability of eventual treatment.
If a 50-year-old expresses a clear, informed preference for resolving the cancer early, taking the functional hit to his erections or continence now while he is young, healthy, and physiologically resilient, rather than living with ongoing, anxiety-inducing monitoring immediate definitive treatment is an entirely reasonable guideline-supported option.
The second exception is borderline pathology features. Imagine a patient whose biopsy shows grade group 1 disease, so mathematically it is Gleason 6.
But they have exceptionally high volume involvement. Let's say 5 out of 12 cores are positive, and some of those individual cores have 60% or 70% tumor involvement.
That patient technically does not meet the strict NCCN, very low risk criteria, due to the high volume, but they might technically still fall into the broader low risk bucket.
However, that sheer volume of cancer inside the gland strongly biologically suggests that there is a higher grade component, a dangerous pattern 4 lurking somewhere in the prostate that the biopsy needle simply missed by a millimeter.
This patient deserves incredibly rigorous confirmatory testing, perhaps an immediate repeat MRI targeted transperineal biopsy, and a very frank, sobering discussion that their likelihood of failing surveillance rapidly is exceptionally high.
A third and heavily researched factor is African American race. Multiple independent large-scale studies have reported that African American men diagnosed with very low-risk prostate cancer have a 1.7 to 2.3-fold higher chance of pathologic upgrading on subsequent biopsies or at the time of radical prostatectomy compared to matched Caucasian American patients.
They also exhibit a higher overall risk of disease progression while on AS.
The mechanisms behind this disparity are complex. Some of it may be driven by distinct tumor biology and microenvironment differences.
But crucial socioeconomic studies suggest that when access to high-quality, equitable care, meaning equal access to top-tier MRI imaging and expert-targeted biopsies is perfectly matched, the biologic differences in upgrading or overall outcomes might be minimized.
The NCCN explicitly notes this disparity, suggesting that strategies to dramatically improve risk stratification for African American men, like aggressive early use of MPMRI, are essential.
The clinical bottom line for you as a resident is this: race alone should never categorically exclude a patient from active surveillance.
However, it absolutely mandates that you heighten the intensity of your confirmatory testing and your ongoing monitoring schedule. You must ensure you have not undersampled a more aggressive tumor in these men.
Our fourth exception involves severe discordance with the MPMRI findings.
If a patient comes to you to discuss AS and their initial MRI shows a massive, bulging PIRADS4 or PIRADS5 lesion, but the systematic biopsy only yielded indolent grade group 1 disease, your clinical alarm bells should be ringing at maximum volume.
A PIRADS5 lesion is highly suspicious for clinically significant high-grade cancer.
The discordance between the dangerous imaging and the benign pathology strongly, almost undeniably points to undersampling.
You should not commit that patient to a long-term surveillance protocol without doing a repeat, highly targeted biopsy of that specific lesion to find the real cancer.
And finally, the fifth exception, which we touched on when discussing the Toronto cohort, is intractable patient anxiety.
Some patients, despite your absolute best efforts to educate and reassure them with the incredible Hopkins survival data, simply cannot tolerate the psychological burden.
Every PSA blood draw feels like a pending death sentence. Every biopsy is physically and emotionally traumatic.
If, after a fully informed shared decision-making process, the patient's quality of life is being fundamentally destroyed by cancer anxiety, definitive treatment is justified to cure their mind as much as their body.
This brings up the ultimate functional trade-off call-out that you must master.
In counseling, we are ultimately comparing the accumulated morbidity of monitoring against the immediate morbidity of treatment.
Active surveillance beautifully, perfectly preserves all functional domains initially. No incontinence, no treatment-related ED.
But it carries the heavy compounding burden of serial biopsies. Remember, there was roughly a 7% adverse event rate per biopsy, including bleeding, urinary retention, and serious sepsis.
Add in the chronic psychological weight, and the journey is arduous.
Immediate treatment, whether surgery or radiation, resolves the cancer definitively and lifts that psychological weight, but imposes severe, upfront functional costs.
You trade the anxiety of watching cancer for the stark reality of managing incontinence, erectile dysfunction, or bowel changes.
As we saw so clearly in Protect, the long-term functional destination at 12 years might look remarkably similar regardless of the path chosen, but the journey to get there is profoundly different, and the quality of that journey matters immensely to our patients.
Let's pull this massive amount of information together by returning to our clinical decision points and applying the case. Let's bring back our 54-year-old healthy gentleman from the beginning.
To review his stats, he has T1C, grade group 1 disease, PSA 4.8, 2 out of 14 cores positive with 20% maximum involvement, and a PSA density of 0.11.
He has no comorbidities. His life expectancy is easily 25 to 30 years.
What is your definitive final recommendation for him?
My absolute recommendation is active surveillance.
Based on what?
The AUA, ASTRO, and NCCN guidelines all strongly and uniformly favor AS for very low-risk disease in men with a life expectancy exceeding 10 years.
And how do you reassure him?
The Johns Hopkins data provides the ultimate statistical reassurance, showing a 99.9% cancer-specific survival at 15 years for his exact risk profile.
But how do you actually frame that conversation to address his specific anxieties about his friends' conflicting advice and the reality of his young age?
I would sit down, look him in the eye, and say something exactly like this. Your cancer falls into the very low-risk category. The massive amounts of data we have from tens of thousands of men show that for someone with exactly your profile, the chance of dying from this prostate cancer over the next 15 years on a structured surveillance program is less than 1 in 500.
That's powerful. What about the monitoring process?
I'd say active surveillance means we are going to watch it incredibly closely. We won't ignore it. We will do blood tests every 6 months, physical exams, MRI scans, and periodic biopsies to check the tissue. If the cancer ever shows any biologic signs of becoming more aggressive or growing, we will immediately pivot and treat it with full curative intent.
And you have to address his young age.
Right. I would add, now, because you are only 54, you have a very long life ahead. Statistically, about half of the men in your exact situation eventually do end up needing treatment over the next couple of decades. But the most important thing you need to hear today is that catching that progression while on surveillance does not compromise our ability to completely cure you.
And if he pushes for immediate surgery?
I'd tell him, if you prefer to undergo treatment right now to simply put the cancer behind you, that is a medically reasonable choice, but you must understand it comes with immediate, permanent side effects to your urinary and sexual function that you would not experience for years on surveillance. This is a decision we will make together.
That is how you counsel a patient. It is balanced, it cites the hard data, and it centers the patient's values and fears. Now, I want to pivot back to the high-stakes environment of your oral boards.
I am ready.
I am going to rapid-fire the 3 exact traps that examiners use to intentionally fail residents in this specific scenario.
Trap number 1, confusing active surveillance with watchful waiting.
If the examiner gives you a 78-year-old patient who has had 2 massive heart attacks, has severe COPD requiring home oxygen, and has an estimated life expectancy of maybe 4 or 5 years.
If you look at the examiner and say, I recommend active surveillance with serial MRIs and annual prostate biopsies, you have failed the station immediately.
You have fundamentally misapplied the concept of intent, that frail patients should be placed on observation or watchful waiting.
No surveillance biopsies. You treat him only if he develops painful symptoms.
AS implies curative intent and demands the physical resilience for structured monitoring for a 10-year life expectancy. Observation implies quality of life intent. Do not mix them up under pressure.
Trap number 2, using PSA kinetics alone to trigger definitive treatment while on AS.
If the examiner tells you that your patient on surveillance has a PSA that doubled from 3 to 6 in 18 months, and you immediately say, the PSA doubling time is dangerously short, I recommend a radical prostatectomy, you have jumped the gun and you will be heavily penalized.
Both Toronto and Hopkins proved PSA kinetics cannot safely replace a tissue biopsy.
A rising PSA must trigger a repeat MPMRI or a repeat biopsy to find the fire, not an immediate trip to the operating room.
Histologic grade reclassification on the biopsy tissue is the validated trigger, not the noisy blood test alone.
Trap number 3, telling a favorable intermediate risk patient that active surveillance is absolutely forbidden.
If the examiner gives you a patient with a tiny 5% volume of grade group 2 disease, a low PSA density, and a favorable genomic score from Decipher, and you state, because you have Gleason pattern 4, active surveillance is not an option and we must treat immediately, you have overstated the rigidity of the modern guidelines.
The AUA, ASTRO, and NCCN guidelines all explicitly support at least discussing active surveillance for highly selected favorable intermediate risk patients.
Blanket dogmatic exclusion of all grade group 2 patients from a surveillance discussion is no longer guideline concordant.
Let's shift to our clinical pearl segment. These are the rapid-fire, high-yield facts you need to memorize cold.
Pearl 1. Active surveillance equals structured monitoring with curative intent, utilizing PSA, DRE, MPMRI, and serial biopsies. Observation or watchful waiting equals symptom-triggered management with palliative quality of life intent. The transition from AS to observation happens strictly when life expectancy drops below 10 years.
Pearl 2. You must know the very low-risk criteria flawlessly. Clinical stage T1C, grade group 1, PSA less than 10, fewer than 3 positive cores, less than 50% involvement of any single core, and a PSA density less than 0.15. AS is the unequivocally preferred management for these patients if their life expectancy is greater than or equal to 10 years.
Pearl 3. The Johns Hopkins AS data at 15 years is your absolute shield in clinic. 99.9% cancer-specific survival, 99.4% metastasis-free survival, despite a 31% grade reclassification rate, and 57% of men ultimately requiring curative intervention. The system works precisely because it catches progression before it escapes the prostate.
Pearl 4. Grade reclassification on a repeat prostate biopsy is the primary validated trigger for leaving AS and initiating definitive treatment. PSA kinetics, like doubling time or velocity, are simply not reliable enough on their own to trigger treatment. They serve only as a smoke alarm to prompt a repeat biopsy.
Pearl 5. The PROTECT trial at 15 years showed statistically similar prostate cancer-specific mortality across active monitoring, surgery, and EBRT at approximately 1.5 to 2.2%. However, monitoring had clearly higher rates of metastasis at roughly 9% versus 4 to 5%, and higher clinical progression compared to immediate treatment. We strongly hypothesize that modern AS with high-resolution MRI integration may narrow this metastatic gap compared to the older passive active monitoring protocol used in the trial.
Pearl 6. Highly selected favorable intermediate risk patients may appropriately be offered active surveillance if they possess a very low volume of pattern 4 disease, a low PSA density, and favorable genomic testing. A blanket automatic exclusion of all grade group 2 patients from surveillance is simply not supported by current oncologic guidelines.
Ready for the board blitz. I'm going to read a clinical scenario, and you give the answer and the deep clinical rationale.
Let's do it.
Question 1. A 75-year-old man presents to your clinic. He has poorly controlled diabetes, severe congestive heart failure, and advanced COPD. His cardiologist estimates his life expectancy is roughly 6 years. He was just diagnosed with grade group 1 prostate cancer, clinical stage T1C. His PSA is 5.5. He had 1 out of 12 cores positive. What is the most appropriate management strategy for this patient? A. Active surveillance with PSA every 6 months and an annual biopsy. B. Observation without any surveillance biopsies. C. Definitive EBRT to 78 gray. D. Radical prostatectomy.
The best answer is B, observation. The clinical reasoning here relies entirely on intent. This patient has very low-risk prostate cancer, but his estimated life expectancy is only 6 years. This falls well below the mandatory 10-year threshold required to even consider active surveillance. His severe, life-threatening competing comorbidities, the congestive heart failure and the advanced COPD, will almost certainly outpace his glacially slow-growing prostate cancer. Therefore, observation, which means monitoring without the physical and psychological burden of surveillance biopsies and treating only if he develops severe symptoms, is the most humane and medically appropriate strategy. Answer A, active surveillance, is completely wrong because the heavy biopsy burden is not warranted when your intent is no longer curative. Answer C, definitive radiation to 78 gray, or answer D, a radical prostatectomy, are completely incorrect because they introduce massive immediate morbidity, gastrointestinal, or genitourinary toxicity that will absolutely not be offset by any survival benefit in a frail man with only a 6-year life expectancy.
Excellent. Question 2. You are following a 58-year-old healthy man who has been on active surveillance for very low-risk prostate cancer, grade group 1 T1C. His baseline PSA was 5.0. Over the last 18 months, his PSA has steadily risen to 8.2. You calculate his PSA doubling time, and it is a concerning 2.5 years. His DRE remains completely normal. What is the absolute most appropriate next step in his management? A. Recommend a radical prostatectomy immediately based on the rapid PSA doubling time. B. Start him on systemic androgen deprivation therapy. C. Repeat an MPMRI and perform a targeted prostate biopsy. D. Continue his routine AS schedule without any additional workup.
The best answer is C, repeat an MPMRI and perform a targeted prostate biopsy. This directly tests the PSA trap we discussed. A rapidly rising PSA and a short PSA doubling time should absolutely prompt further, urgent clinical evaluation, but it must never prompt immediate blind treatment. Both the Toronto and the Hopkins research groups demonstrated that PSA kinetics alone are notoriously noisy and unreliable for accurately predicting true histologic biopsy reclassification. The only appropriate response to that smoke alarm is to obtain repeat imaging and biopsy tissue to determine if actual pathologic grade reclassification has occurred. If that repeat biopsy still shows low-volume grade group 1 disease, you can confidently continue active surveillance. If it shows an upgrade to grade group 3, then you recommend treatment. Answer A is wrong because PSA doubling time does not trigger the scalpel. Answer B is wrong because ADT alone is almost never indicated for localized low-risk disease. And answer D is wrong because ignoring a rapidly rising PSA and just seeing him in a year is negligent. It warrants immediate investigation.
Spot on. Last question. Question 3. A 55-year-old man is diagnosed with grade group 1 prostate cancer, Gleason 3 plus 3 equals 6, clinical stage T1C. His PSA is 6.5. The biopsy showed 2 out of 12 cores positive with a maximum core involvement of 10%. You calculate his PSA density to be 0.10. So far, he looks like a perfect candidate. However, his pre-biopsy MPMRI showed a very prominent 1.8 centimeter PARDS, 5 lesion in the right peripheral zone. He's asking if he can start active surveillance today. Which specific finding in his workup most warrants intense concern that his initial biopsy may have significantly underestimated the true severity of his disease? A, the PSA density of 0.10. B, the fact that he has 2 positive cores out of 12. C, the PIRADS 5 lesion on the MPMRD, the maximum core involvement of 10%.
The best answer is C, the PIRADS 5 lesion on the MPMRI. PIRADS 5 categorization on an MRI carries an exceptionally high statistical probability of harboring clinically significant, high-grade cancer based on restricted diffusion. When you have a physical biopsy that yields only indolent grade group 1 disease, but it is sitting right next to a highly suspicious PIRADS 5 lesion on the imaging, that massive discordance is a glaring red flag. It raises a severe, immediate concern that the biopsy needle simply missed the most aggressive, dangerous component of the tumor by a fraction of an inch. The NCCN specifically warns that patients with PIRADS 4 or 5 lesions on their MPMRI prior to initiating AS have a significantly increased risk of subsequent biopsy progression. In this scenario, you must perform a repeat, highly targeted biopsy to adequately resample that PIRADS 5 lesion before you ever commit him to a long-term surveillance protocol. The imaging is trying to warn you that the pathology report is incomplete. The other answers are all incorrect because a PSA density of 0.10, 2 positive cores, and 10% involvement are all very reassuring low-volume metrics that do not drive undersampling concerns.
That brings us to the end of our comprehensive review. As we pull this entirely together, the core clinical takeaway from today's lecture is that active surveillance is the definitively preferred guideline-recommended management strategy for very low and low-risk prostate cancer.
It is not a fallback option. It relies entirely on rigorous, structured monitoring with PSA, MPMRI, and serial biopsies to catch biologic reclassification in time to deliver curative intent therapy.
The staggering Hopkins data, showing 99.9% cancer-specific survival at 15 years, is the ultimate proof of concept.
And you must never ever confuse this with observation, which is symptom-triggered palliation for men with less than a 10-year life expectancy. We also explored the expanding, heavily debated frontier of offering AS to highly selected favorable intermediate risk patients.
Finally, We must remain hypervigilant for the exceptions within the low-risk category. The very young men staring down decades of biopsies, those with high-volume disease, African American men who may face higher upgrading risks, patients with discordant high PIRADS lesions, and men whose psychological anxiety severely degrades their quality of life.
These factors demand transparent, empathetic discussions about the complex functional trade-offs between the accumulated morbidity of monitoring and the immediate morbidity of treatment.
Next time, we are going to shift our focus entirely to definitive treatment. Part 4 will cover prostate cancer, definitive EBRT, dose escalation, and moderate hypofractionation. We will get deep into the technical weeds of radiation delivery and target volumes.
Complete practice oral boards at radronsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.